When a fire alarm goes off in a building, I mean, the immediate instinct is to look for the fire, right?
Right, yeah. You smell smoke, you hear the alarm, you just assume there are actual flames somewhere.
Exactly. But imagine running through that building, with an extinguisher in hand and finding absolutely no flames. Like the alarm is blaring, the smell of smoke is undeniable, but there's just no actual fire to put out.
It's incredibly frustrating. And honestly, that phantom fire is a perfect analogy for what we're looking at today.
Yeah, so welcome to today's deep dive. We are taking this massive stack of medical guidelines. We've got the British Association for Sexual Health and HIV, the NHS, the Centers for Vulvovaginal Disorders, and the Royal Australian College of General Practitioners. And we're using them to answer a really specific, highly complex medical mystery.
It's a huge question for so many patients.
It really is. The mission today is to figure out, can an overgrowth of strict anaerobic bacteria in severe recurrent bacterial vaginosis cause a chemical vulvitis that triggers entry burning?
And to solve this, we really have to separate the actual physical biology of these bacteria from the incredibly complex ways the human body and our hygiene habits respond to it.
Right, and for you listening, the stakes here are just immense. I mean, chronic pelvic pain and vaginal discomfort, it's so frustrating. And the data across these sources shows that misdiagnosis in this specific area is shockingly common.
It happens all the time, unfortunately.
Yeah, so by understanding the exact biological and chemical mechanics of what happens during a BV recurrence, you will just be so much better equipped to advocate for your own health. It's about knowing enough to, avoid standard treatments that the literature says might actually make things infinitely worse.
Exactly. So to understand the malfunction, we first need to look at the baseline, right? We have to understand what is physically and chemically happening during a recurrence of bacterial vaginosis, or BV.
Okay, well, let's get into it.
So the clinical guidelines describe the vaginal ecosystem as this highly regulated environment. In a healthy state, the dominant presence is a group of bacteria called lactobacilli.
And the sources use this really great analogy, essentially describing those lactobacilli as like a protective ground cover in a thriving garden.
I like that, yeah.
As long as that ground cover is dense and healthy, weeds just can't really take root.
Yeah.
The lactobacilli actively maintain an acidic environment, keeping the vaginal pH, I think it's between roughly 3.8 and 4.5.
That's right. And that acidity is the primary defense mechanism. But the clinical data shows that when those lactobacilli decrease, and this happens for reasons we honestly don't fully understand yet, like hormonal shifts or menstruation, the pH rises above 4.5.
Which is a bigger deal than it sounds, right? Because the pH scale is logarithmic.
Yes, exactly.
Yeah.
So a shift from, say, 4.0 to 5.0, that represents a massive environmental change. And that alkaline shift basically acts as a green light for strict anaerobic bacteria, things like Gardnerella vaginalis, Prevotella, and Mobiluncus, to just rapidly overgrow.
And the defining characteristic of these anaerobes is that they thrive in environments without oxygen. So as they stage this hostile takeover of the microbiome, the literature notes they actually build this protective structure.
The biofilm, right.
Yeah, they secrete a polymeric matrix, this biofilm, that just stubbornly anchors them to the vaginal wall. It basically shields them from the body's immune system and even from standard antibiotics.
It's incredibly resilient. So we are looking at an imbalance here, right? An ecological shift rather than a traditional infection that you catch from someone else.
Right, it's an internal shift.
Yeah. And that biological shift brings us to the actual biochemistry of the condition. As these strict anaerobes overgrow inside that biofilm, they metabolize differently than the lactobacilli do. They start breaking down amino acids in the vaginal fluid.
Okay, and this is where it gets really interesting for our chemical question.
It does. The byproducts of this specific metabolic breakdown are compounds known as volatile amines.
And the specific names listed in the biochemistry data for these are putrescine and cadaverine, which, those are very descriptive, harsh-sounding names.
They really are, and they are universal metabolic byproducts of anaerobic bacterial breakdown in nature. But in the context of recurrent BV, the production of these amines is actually exactly what clinicians test for.
Oh, right, the whiff test.
Exactly. When a doctor performs what the guidelines call a whiff test, they take a vaginal fluid sample and add a drop of potassium hydroxide, or KOH.
And that causes a reaction, right?
Yeah. The KOH rapidly raises the pH of the sample, which forces those amines to convert into a volatile gas. And that gas release is what produces that characteristic pungent, fishy odor that's so heavily associated with the condition.
Wow. Okay, so we've established this really clear chain of events. The protective lactobacilli die off.
Yeah.
The pH rises, the strict anaerobes overgrow, and then they start pumping out these heavily concentrated volatile amines, the putrescine and cadaverine.
That's the chemical reality, yes.
So this perfectly sets up the core question of our deep dive today. We have a highly sensitive area of the body suddenly flooded with these harsh chemicals. It seems, entirely logical to just ask, do these chemicals physically burn the skin?
It's the most intuitive question to ask.
Right. But when we cross-reference this biochemical reality with the actual symptom guidelines in our stack of sources, we hit a massive wall.
We really do, because if you look at the primary clinical guidelines, from the NHS, BSHH, the West of Scotland Managed Clinical Network, they share this striking absolute consensus.
Wow.
They explicitly state that BV is not typically associated with soreness, itching, irritation, or vulval inflammation.
Which is wild. It's just wild that the NHS and BSH guidelines are so definitive about BV, lacking inflammatory symptoms.
Yeah.
Especially when you consider how many patients report the exact opposite.
Yeah, the classic textbook symptoms they list are literally just limited to a thin grayish-white discharge and that noticeable amine odor. They actively rule out tissue inflammation as a primary symptom.
Which creates this huge disconnect, right, between the textbook definition and the actual lived experience of so many patients.
It's a huge disconnect.
And what's fascinating is that this contradiction is actively documented in our own stack of sources. Like, I'm looking at the Royal Australian College of General Practitioners guidelines, the RACGP right now, and they diverge from the British guidelines.
What do they say?
Well, the RACGP explicitly notes that while less common, BV can sometimes cause burning. So we have a direct contradiction in the medical literature here. The British guidelines say no inflammation. The Australian guidelines say actually it can cause burning.
And we know the pain these patients feel is very real. It's not in their head.
No, absolutely not.
Yeah.
So for you listening, ponder this dilemma. If the prevailing medical consensus is that BV isn't an inflammatory condition, why are women with BV experiencing this physical burning sensation?
To solve this symptom paradox, the literature suggests we actually need to shift our geographical focus a bit.
Okay, where are we looking?
Well, we've been looking at the internal environment of the vagina, right, where the bacteria and the amines are produced. But the clinical data on burning points us outward to the external entryway, the vulvar vestibule.
Okay.
When a patient experiences severe pain, burning, or this raw sensation upon entry or pressure right at that vaginal opening, it falls under a clinical diagnosis known as localized provoked vestibulodynia, or LPV.
LPV. And looking at the diagnostic criteria for LPV in the sources, the vestibule is uniquely vulnerable.
Yes, very.
The tissue there is non-keratinized epithelium, which, unlike the skin on our arms or legs, which has this tough outer layer of dead skin cells to protect against the environment, the vestibule lacks that protective armor. It's highly permeable.
Exactly. And the sources list several potential causes for entry pain in this specific area, like dense nerve endings or pelvic floor muscle dysfunction. But the one most relevant to our chemical question is something called secondary vestibulitis.
And that's caused by external irritants, right?
Correct. The Centers for Vulvovaginal Disorders, the CVVD, they categorize this specific reaction as chemical vulvitis or irritant contact vestibulitis. Because that non-keratinized tissue is so permeable, it's highly susceptible to chemical burns.
The list of everyday chemical irritants the vulva is exposed to is just extensive.
It really is.
The CVVD sources list things that most people wouldn't even think twice about. Urine and feces, obviously, but also perfume soaps, bubble baths, laundry detergents used on underwear, fabric softeners, even the chemical compounds in latex condoms.
Right. Everyday items.
Yeah, and the literature states that any of these can strip the minimal lipid barrier on the vestibule, triggering an allergic reaction or acting as a direct chemical irritant that inflames the tissue.
And that localized tissue inflammation is exactly what the patient registers as a burning pain.
Okay, so we have the biological reality of chemical vulvitis caused by irritants, and we have the biological reality of BV producing chemical amines, putrescine and cadaverine. It feels like the most natural deduction in the world to connect those two data points.
Right. Are the amines produced by the Gardnerella bacteria acting just like those external soaps and detergents?
That's the million-dollar question. Are the bacteria themselves secreting the specific chemicals that directly cause irritant contact vestibulitis and burn the entryway?
Right. So what do the CVVD sources actually say? Do they connect it?
Well, it's the most common logical leap made by both patients and a lot of clinicians. You identify a harsh chemical presence and you identify a burning sensation, so you assume cause and effect.
Right. Where there's smoke, there's fire.
Exactly. But when we look at the specific pathology data provided by the Centers for Vulvovaginal Disorders, they draw a very hard, definitive line that completely shatters that assumption.
Oh, wow. Okay. Break that down for us.
The CVVD data focuses heavily on a crucial clinical distinction between a vaginosis and a vaginitis.
Okay. Vaginosis versus vaginitis.
Yes. The suffix osis implies an imbalance or an abnormal condition, whereas itis specifically denotes active inflammation.
Ah, I see. That distinction is everything here. The CVVD explicitly outlines the pathology of vaginal inflammation. When an inflammatory pathogen is present, the body's immune system mounts a defense. It sends white blood cells to the area.
Right, the standard immune response.
Right, and severe vaginal inflammation causes these white blood cells to physically pour out of the vagina. These inflammatory cells then coat that delicate non-keratinized tissue of the vestibule, directly causing a secondary vestibulitis, which is that burning pain.
But I'm looking at the text here, and it's incredibly specific about what actually triggers that immune response. It states this massive outpouring of white blood cells is caused by infectious inflammatory organisms like yeast and trichomonas.
Yes.
But then it explicitly says, but not bacterial vaginitis, pointing directly to Gardnerella, which is the primary bacteria in BV.
That is the aha moment right there. The data reveals that the strict anaerobes simply do not trigger that massive white blood cell response. The immune system does not view the Gardnerella biofilm in the same way it views a fungal invasion like yeast.
So even though the amines have that strong odor, they aren't shown in this literature to act as direct inflammatory agents on the vestibule tissue, not in the way that an outpouring of immune cells does.
Exactly.
Okay, so the strict anaerobes in recurrent BV are not the arsonists. The bacteria aren't actively burning the tissue, but, and this is a big state, but we still have patients with recurrent BV experiencing debilitating entry pain.
Right, the pain is still very real.
Yeah. So if the internal bacterial chemistry isn't starting the fire, the burning has to be coming from the environment. What is actually causing the tissue damage?
Well, the sources reveal that the burning is almost entirely secondary. It is the human reaction to the recurrent BV that creates this perfect storm for entry burning. The data outlines 3 specific intersecting mechanisms that actually cause the pain.
Okay, let's look at the first mechanism detailed in the CVVD data. Hygiene practices.
This is a huge one.
When a patient notices the characteristic odor of those volatile amines, the immediate, completely understandable human reaction is to try and wash it away.
Of course it is. But as we discussed, that non-keratinized tissue is incredibly vulnerable. The sources note a heavy reliance on harsh, perfumed soaps, bubble baths, excessive washing, and vaginal douching by patients who are just desperately trying to manage the BV odor.
They're trying to fix it.
But biologically, these alkaline soaps completely strip away what little protective lipid barrier exists on the vulva. The perfumes and the chemical surfactants then directly penetrate the tissue. The data explicitly states that this overwashing is a primary direct cause of chemical vulvitis and irritant contact vestibulitis.
That is so incredibly frustrating. So in an attempt to wash away the harmless, albeit unpleasant smoke of the amines, the patient is unknowingly applying the very chemical irritants that actively burn the sensitive tissue of the entryway.
Exactly. You are introducing known chemical irritants to a highly sensitive area, basically to mask a symptom of a bacterial imbalance. And that leads directly into the second, perhaps more insidious mechanism that the data points to,
which is misdiagnosis and inappropriate treatment.
Yes.
The literature emphasizes how frequently this happens. Because recurrent BV causes discharge and a sense of general discomfort, it is routinely mistaken for a yeast infection. By patients self-diagnosing, sure, but also by doctors performing really quick visual exams.
It's misdiagnosed constantly. And the CVVD notes that almost all women presenting with chronic vulvar pain have been subjected to multiple, completely unnecessary courses of over-the-counter or prescription antifungal creams.
Antifungal creams for a bacterial imbalance.
Right. And this is where the mechanism of the pain becomes incredibly clear. The clinical data on acquired nerve pain, specifically what they call secondary neuronal proliferation, links directly back to these treatments.
Wait, secondary neuronal proliferation. The term proliferation implies that the physical nerves in the tissue are actually multiplying. How does the standard over-the-counter yeast cream cause nerves to grow?
It all comes down to chronic irritation. When you repeatedly apply an antifungal cream to tissue that does not actually have a fungal infection, the active ingredients, along with the vehicles of the cream, things like the preservatives, the stabilizers, the propylene glycol, they act as chronic chemical irritants on that non-keratinized epithelium.
So the tissue is essentially just soaking in harsh chemicals it doesn't even need.
Precisely, and the body responds to this constant low-grade chemical irritation by releasing inflammatory mediators. One of those mediators is nerve growth factor.
Oh, wow.
Yeah, and over time, the constant presence of nerve growth factor causes the tissue to literally sprout new nerve endings. The tissue physically rewires itself, becoming hyperdense with pain receptors.
That's terrifying.
It's a condition called allergic contact vestibulitis that leads to acquired neuroproliferation. The area just becomes exquisitely hypersensitive to any touch or pressure.
That is a staggering biological mechanism. A patient misdiagnoses the BV as yeast, applies a cream to fix a fungus they don't even have, and the chemicals in the cream not only cause a chemical burn, but actively force the tissue to grow new pain receptors.
The treatment actively creates a chronic pain condition.
Unbelievable. Which brings us to the third mechanism highlighted in the literature, which isn't chemical at all, but biomechanical, right? Pelvic floor tension.
Yes. The psychological and physical toll of recurrent BV really cannot be overstated here. The chronic anxiety of dealing with the odor, the frustration of treatments that just don't work, and the anticipation of pain during intimacy or even just sitting down causes a profound neuromuscular reaction.
And the sources refer to this as pelvic floor hypertonicity or vaginismus. But how does the anticipation of pain actually create physical burning upon entry?
It's essentially a subconscious guarding mechanism. The brain anticipates pain, so it signals the muscles of the pelvic floor, the muscles surrounding the vaginal entryway, to clench and protect the area.
Like tensing up before you get hit?
Exactly. But when these muscles are held in a state of chronic tight contraction for long periods, they become exhausted. Blood flow is restricted and lactic acid builds up in the muscle tissue, very much like a severe muscle cramp.
Oh, okay.
This hypertonicity makes the muscles themselves incredibly tender and sore. So when any pressure is applied to the vestibule, the tightened, inflamed muscles underneath send severe pain signals to the brain. The anxiety about the condition is actively dictating a physical pain response.
Wow. So if we step back and look at the comprehensive picture painted by these clinical guidelines, the mystery of the phantom fire really becomes clear. We set out today to find out if the anaerobic bacteria in recurrent bacterial vaginosis are producing chemicals that directly burn the vestibule.
And the revelation from the pathology data is a resounding no.
No. The strict anaerobes, the Gardnerella, they aren't the arsonists. I mean,
Right.
yes, they change the pH, they create a biofilm, and they produce volatile amines that cause odor, but they are just the smoke. The actual arsonists, the elements physically burning the non-keratinized tissue of the entryway, are the harsh soaps used to manage the odor, the unnecessary antifungal creams that trigger nerve proliferation, and the lactic acid buildup from pelvic floor tension caused by the stress of the whole ordeal.
The clinical evidence points entirely to that conclusion. The biological imbalance definitely changes the vaginal environment, but it is the human intervention, the overwashing, and the misdirected medical treatments that ultimately causes the cellular tissue damage and the acquired nerve pain.
So to summarize this for you listening, we took a deep dive into the medical consensus on recurrent BV and entry burning. And while the strict anaerobes absolutely shift the vaginal ecosystem and produce chemicals like putrescine and cadaverine, the major diagnostic guidelines, supported by the pathology data from the CVVD, confirm that these bacteria do not directly cause inflammatory chemical vulvitis.
They do not.
If you have recurrent BV and are experiencing that raw, burning pain at the entryway, the literature strongly suggests it is a secondary effect. The pain is highly likely the result of irritant contact vestibulitis from soaps, acquired neuroproliferation from unnecessary yeast infection creams, or the biomechanical tension of the pelvic floor muscles.
And the clinical value of understanding these distinct mechanisms is paramount. Recognizing the profound biological difference between an infectious, white blood cell producing inflammation like yeast and a bacterial ecosystem imbalance like BV, it completely changes how you manage your health.
It really empowers you to break the cycle of self-harm through misdirected treatment. Like if you know the bacteria aren't causing the burn, it stops you from desperately applying over-the-counter treatments that strip your lipid barrier and literally force your tissue to grow new pain nerves.
Right.
It allows you to walk into a clinic and say, hey, I understand the mechanics of BV. I know these topical treatments might irritate my vestibule. Let's investigate the secondary causes of this pain.
It moves the patient away from reactive panic and toward informed, precise management of the actual underlying tissue or muscle dysfunction, which is huge.
It's massive. But before we wrap up this deep dive, I want to leave you with one final thought to mull over And this is drawn straight from the treatment guidelines in our sources.
Yeah.
When BV is correctly diagnosed, the standard medically approved treatment is a course of antibiotics to destroy the anaerobic biofilm.
Yes, but antibiotics are indiscriminate. The sources note that this treatment wipes out everything, including whatever protective lactobacilli, that vital ground cover, you might actually have left.
Right, so by entirely clearing the biological slate, the environment is left without its primary acidic defense mechanism.
Exactly.
And the data shows that wiping out the lactobacilli frequently opens the door for a fungal organism, like yeast, to rapidly take hold. And we know definitively from the CVD pathology data that yeast infections do cause a massive outpouring of white blood cells, resulting in severe inflammation and actual chemical burning of the vestibule.
Which is a brutal irony.
It is. So take a moment to ponder the incredible, delicate complexity of the human microbiome. Are we sometimes caught in this modern medical loop, where the standard cure for one biological imbalance is mechanically setting the stage for the next? We medically extinguish the phantom smoke of the bacterial imbalance, only to inadvertently spark a very real, biologically verified fire of yeast inflammation.
It's a sobering thought.
It really is. The next time that alarm goes off, before you reach for the chemical extinguisher, make sure you know exactly what is actually burning.